Hello, my name is Molly Morgan. Today I'm going to be speaking about heart failure. Let's start with the basics. Heart failure is a medical condition in which the heart cannot pump enough blood to the body, which results in the body being unable to function properly. Heart failure can come from other diseases such as obesity, diabetes, anemia, iron overload, and cancer treatments. It is apparent that COVID-19 can also increase the risk for heart failure. There are two different types of heart failure, left versus right-sided heart failure. They both present differently. An ejection fracture of 40% or less than 40% is indicative of heart failure. It is important to know that heart failure is extremely prevalent in the world. 10 in 1,000 people after 65 years of age are diagnosed with heart failure in the United States. 26 million people worldwide are diagnosed with heart failure. Next, we are going to talk about a complex patient I had in clinical. My patient was a 63-year-old Caucasian man. He presented to the emergency department the day before with complaints of shortness of breath since earlier in the morning that day. He denied any chest pain and chest palpitations. He does not wear oxygen at home, however, he does have a CPAP. The patient stated he has gained 12 pounds since the month prior to his admission in the emergency department. He has an extensive history of cardiac problems, such as atrial fibrillation, arrhythmia, coronary artery disease, hyperlipidemia, and hypertension. In addition to these medical conditions, he also has a history of kidney stones, sleep apnea, and type 2 diabetes mellitus. The patient also has a family history of heart disease. The patient has a BMI of 50, which puts him at the morbidly obese BMI range. Upon assessment in the emergency department, the nurse noted that the patient had +3 pitting edema that has recently worsened to a +4. The patient also had an irregular pulse rate of 113, blood pressure was 139/82, temperature was 98.4, oxygen was 92% on room air, and he had a respiration rate of 26, which was also irregular. As you can see from the slide, my patient had very similar risk factors to those of heart failure. Many of the heart failure risk factors align with the complex patient's issues such as age, family history, lifestyle, and comorbidities. The patient's ejection fracture was less than 40%, which we previously learned is a sign of heart failure. Now we can talk about treatment for the patient. The patient had never been cardioverted before, and he was admitted to the Christ Hospital's cardiovascular step-down unit, where he underwent a cardioversion the day after he was admitted to the hospital. He was then scheduled for an ablation for April of 2022. The patient was educated on heart failure and provided with goals to manage his disease. Goals included a low-sodium diet with fluids less than 2 liters a day, an increase in physical activity, and finally monitoring daily weights. It was important to add that he should monitor daily weights because he had gained 12 pounds in the last month. It appears his treatment plan was consistent with national heart failure treatment. Heart transplants can be used in heart failure cases when the patient meets certain criteria. Next, we will talk about pharmacology in the next slide. My patient was prescribed amiodarone, atorvastatin, carvedilol, Lasix, insulin, valsartan, and diltiazem. The medications that were prescribed for him treated his AFib, hyperlipidemia, helped diurese him, and controlled his blood pressure and heart rate. All of these are also consistent with national heart failure pharmacotherapies. I am curious to know why the patient was not prescribed an ACE inhibitor with his new diagnosis, but I am assuming since he responds well to the beta blocker carvedilol, he wouldn't need the ACE inhibitor on top of that as well. The patient was very knowledgeable about the use of insulin, which is also a part of his heart failure treatment, since it is important to keep comorbidities managed. The plan of care for my patient is listed on this slide as well. Upon assessment in the emergency department, we know that the patient was short of breath, in AFib, had a high blood pressure and high heart rate with a lower oxygen saturation and an irregular pulse rate. He has a family history of heart disease and a past medical history of heart complications. The goals for that shift that I was with my patient included maintaining an oxygen saturation above 95%, preventing further fluid overload, maintaining comfortability, and providing education based on the patient's new diagnosis of heart failure. Nursing interventions including keeping the patient in a semi to high Fowler's position, monitoring daily weights, maintaining fluid and sodium restrictions. These ended up being a help because my patient went down for his cardioversion that day and he couldn't have anything in his system. Oxygen therapy was provided PRN and vital signs were monitored every 4 hours while keeping a telemetry box on the patient at all times to monitor his sinus rhythm. The patient met his expected outcomes. After the cardioversion, the patient was in normal sinus rhythm with a heart rate in the 60s. He stated he was feeling better. I listened to his heart, and I could hear his heart beating in rhythm. He maintained a 95% oxygen saturation throughout the shift. He never had to wear his oxygen. The patient did not report any feelings of shortness of breath. Edema and bilateral lower extremities improved as well. The patient's weight also started to go down from the previous day as fluids were maintained and he was on Lasix. The patient was educated on signs and symptoms of heart failure management and general information about heart failure successfully. I created a nursing care algorithm focused on heart failure and what the process of suspicion of heart failure to treatment of heart failure looks like. Heart failure can be suspected from a patient's medical history and physical examination. The medical history includes a family history of heart disease, cardiac disease, risk factors, comorbidities, and symptoms. The physical examination includes vital signs, weight gain or fluctuations, heart, lung, and abdominal and peripheral vascular assessments, and edema. If heart failure is no longer suspected after review and assessment, the physician and the patient should explore other possible diagnoses. If heart failure is still suspected, diagnosis tests will be ran. A BNP greater than 100 indicates abnormal heart function. My patient had a BNP above 100, which also contributed to his heart failure diagnosis. An echocardiogram may also be done, along with a stress test and a cardiac catheterization. Treatment includes pharmacotherapy and management of comorbidities, a healthy lifestyle, daily weights, and fluid restrictions. Typically in the hospital with patients that have heart failure, I've seen that they could be restricted by 2,000 milliliters or 1,500 milliliters a day. In conclusion, heart failure refers to the heart's inability to pump enough blood efficiently to the rest of the body. The body will not be able to function properly, so the patient will experience abnormal signs and symptoms that will indicate an issue with perfusion. Heart failure is most common in men 65 years and older, specifically in African American men. Risk for heart failure is increased with comorbidities. With the help of medicine and lifestyle changes, heart failure can be better managed.